Now moving on to our next session, which is again a very important topic as far as cancer is concerned, neutropenic sepsis. So we request our chairpersons for the session, Dr. Sudha Kansal. Dr. Sudha Kansal is a senior consultant at Indraprastha Apollo Hospitals, and she has multiple publications and various journals and textbooks in her name. Her main interest in work is sepsis, ventilation and acid-base disturbances. Welcome, ma'am. We now have with us our second chairperson, Brij Mohan, Dr. Brij Mohan. He is associate consultant at Fortis Shalimar Bagh, New Delhi. Welcome, sir. Thank you, ma'am.
Good morning, friends. At the outset, I'd like to congratulate Dr. Murali for inception of this new society. It was really a need, so much cancer. We see almost 50% of patients admitted in ICU have cancer. And she's done just such a wonderful job. A big hand of applause. Who has so many societies and so many things with her, and you also have one. Now I'd like to introduce our next speaker, Dr. Deepak Govil. He doesn't need any introduction. All our ICU people and intensivists, they know him. But I still have to do it as a formality. Currently, he is the Vice Chairman, Critical Care Medicine, Institute of Critical Care and Anesthesia, Vedanta, the Medicity, Gurgaon. He has all the possible affiliation with the Indian Society. He has been past President, Indian Society of Critical Care Medicine, past Vice Chancellor, Indian College of Critical Care Medicine, past Controller of Examination, Indian College of Critical Care Medicine. He is a Director of Focus, IPO Delhi. One of the first society to make intensive care ultrasound so popular. And he is also a council member of World Federation of Intensive and Critical Care. Area of expertise are all but mainly ventilation, hemodynamic monitoring, ultrasound and sepsis management. Dr. Deepak Govil.
Oh, thank you, madam. Thank you, Madam Chairperson, for such illustrious introduction. First of all, I would like to thank Dr. Kaur and Dr. Das for presenting such a beautiful initiative and inviting me here. So I'm going to talk about the neutropenic sepsis, as Dr. Chawla has already set the stage rolling, in which we'll discuss some definitions. He has already covered few things, but probably might have some overlap. So what's neutropenia is defined as an absolute neutrophil count of 500 cells per cube or less than 1000 cells per cube with an anticipated decline to less than 500 cells within 48 hours. And what's febrile neutropenia? Neutropenia with a single oral or tympanic temperature greater than or equal to 101 degree Fahrenheit, that equivalents to 38.3 degree centigrade, or greater than or equal to 100.4 degree Fahrenheit or 38 degree centigrade for at least 1 hour. So this difference is slight difference in the febrile definition. Then comes the sepsis. What do we mean by sepsis? Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to any infection. And septic shock we call when there is a subset of the sepsis where underlying circulatory, cellular or metabolic abnormalities contribute to a greater risk of mortality than the posed by the sepsis alone. So we have to consider these two aspects as well while we are dealing with the neutropenic sepsis patients. Why the neutropenia is so important here? The neutrophil is a specific type of the white cell that plays an important role as a body's first line of defense. The neutrophil usually make up about half to two-thirds of the whole white cells and protect against bacterial infections. In addition to neutropenia, disruption of mucociliary barriers, extensive use of invasive device, and shifts in the inherent microbial flora due to prolonged antimicrobial usage predisposes these patients to the infection. So this is how we define the different degree of the neutropenia. Mild neutropenia, where absolute neutrophil count is 1000 to 1500. Moderate neutropenia, where it is 500 to 999. Severe neutropenia, 100 to 499. And profound neutropenia, less than 100. Why we see more infections in neutropenic patients nowadays? Because their incidence is increasing. More invasive regimes are there for cancer therapies. Mucosite is there. Prolonged profound neutropenia is there. Increased use of indwelling catheters are there. Bone marrow transplant patients, they are highly immunosuppressed. And the prognosis will depend on the severity of illness, organ dysfunction, and not on the severity of neutropenia. We have to consider this aspect, because many times we feel that degree of neutropenia is directly related to the severity of illness. It is not like that. So how we evaluate these patients? As any evaluation, we start with the history. We have to look for previous such episodes, associated localizing symptom like ear, nose, throat, respiratory, gastrointestinal, musculoskeletal and urogenital system abnormalities, nature of chemotherapy. It depends on it will reflect on the expected duration of the neutropenia. Then previous cultures, if patient is growing any MDR pathogen, and prophylactic use of antibiotics and concomitant use of steroids. That happens in many chemotherapeutic agents adjuvantly. So in physical examination, patient may appear well despite being hemodynamic compromises. So evaluate vitals very carefully. Sites missed are oral cavity, ear, sinuses, perineal area, intravascular catheter insertion sites, and sites of the bone marrow aspiration. Generally miss these sites. As you can see here, a small looking like a lesion can cause a big problem in these patients. So in eyes, conjunctivitis, oral orbital cellulitis, in ear, nose, throat, otitis media, tonsillitis, pharyngitis, sinusitis, dental caries, abscesses, pneumonia, diarrhea, dysentery, enterocolitis, perineal candidiasis, perineal abscesses, cellulitis, abscess, furniculitis, meningitis, meningoencephalitis, urinary tract infection, and in intravenous catheters, the exit site infection could be main possible sites of the infection. Risk categorization is very important in these patients, because then we have to understand where these patient has to be shifted, where they has to be treated, and which type of antibiotic, oral, IV, intensive therapy need to be given. So risk categorization correlates to the risk of serious medical complication, including mortality, and it is used to determine treatment settings, inpatient versus outpatient, empiric antimicrobial therapy, oral versus IV therapy, and duration of antimicrobial therapy as well. Patients at high risk are more likely to experience a severe infections. Risk factor for neutropenic sepsis are chemotherapy, advanced disease, history of prior febrile neutropenia, no antibiotic prophylaxis or colony stimulating factor use, mucositis, poor performance status, or cardiovascular disease in such patients. So this is a multinational association for supportive care in cancer, which has given a risk factor score, burden of illness. It includes the number of mild symptom, moderate symptom, hypotension, chronic obstructive pulmonary disease, solid organ or hematological malignancy with no previous fungal infection, dehydration, outpatient status, and adult age more than 60 years. So these are taken as a criteria, and the points have given according to the thing. And score more than or equal to 21 indicates low risk. So less the score, more risk is there. More the score, less risk is there. So if any patient with temperature with neutrophil count less than 500 is coming to then prompt assessment and vigorous resuscitation is needed. Calculate this score. If a score is less than 21, patient becomes a high risk, and then one has to consider the inpatient broad spectrum intravenous antimicrobial therapy. If a score is more than 21, then patient is a low risk. Then inpatient oral antibacterial therapy can be started in some cases. So febrile neutropenia with ANC less, then clinical assessment with the scoring, then we go to this investigation. So what investigation we require here? Main routine investigations are CBC with ANC, renal hepatic function, coagulation profile, blood culture, specifically 2 sets, urine analysis and culture, sputum microscopy, stool microscopy and culture, the chest x-ray, CRP, procalcitonin, and further we can go for a high resolution chest CT scan if pyrexia after 72 hours of appropriate antibiotic is there, and if pneumonia is non-resolving, we can go early BAL maybe in 72 hours in these patients. These are the empiric antimicrobial choices where the anti-pseudomonal beta-lactamase agent has to be added in such case in patients with our high-risk patients with neutropenic fever. It's a A1 grade recommendation. Carbapenem, meropenem or imipenem celestine, piperacillin tazobactam, aminoglycosides, vancomycin can be used. Vancomycin, linezolid or daptomycin, linezolid or daptomycin or carbapenem to be used in patients with risk of methicillin-resistant Staphylococcus aureus or the vancomycin-resistant Enterococcus. Polymyxin, colistin or tigecycline, maybe the ciprofloxacillin, clindamycin, aztreonam and vancomycin is to be used where the risk of Klebsiella pneumoniae with the carbapenemase is more high. So up to 50% of patients have respiratory failure, those who are having the neutropenic sepsis, and the factors could be the delay since the starting of antibiotic prophylaxis, after diagnosis of the cancer, immunodeficiency, radiographic appearance of the chest shadows, experience and knowledge of the literature, clinical picture like ongoing chemoprophylaxis and effective antibiotic cover, and finding on the HRCT scan. And should be when we should do the fiber optic bronchoscopy and BAL in such patients, probably in the early phase once you feel that 1 or 2 day therapy is having no effect, and use NIV with the caution in these patients. ARDS risk is severe and prolonged neutropenia is very high, and please avoid the colonium stimulating factors at this point of time. If patient has an IV catheter related infection should be suspected. The differential time to positivity of plus minus 2 hours is a highly sensitive and specific indicator of catheter related bacteremia. So we have to stress upon the differential time positivity in both the paired sample, one from central line and one from peripheral line. Vancomycin or teicoplanin should be given when possible to cover gram-positive organism. Removal of the line is indicated in the context of the tunnel infections or pocket infections. So if a port is implanted and if there is a tunnel infection or pocket infection, then we have to remove it. Persistent bacteremia despite adequate treatment, one has to consider the atypical mycobacterial infection or candidemia in these patients. So this is a logarithm: severe infection in neutropenic patients in the ICU, acute respiratory failure one can have, direct investigations, non-invasive test, bronchoalveolar lavage, can use NIV if isolated acute respiratory failure is there, early phases, and if it is not resolving, then one should go for mechanical ventilation. If central venous catheter related infections are there, look for the local signs of the infection, or if there is no local sign infection, no obvious after source of infection plus septic shock, then one can remove the catheter. Non-neutropenic enterocolitis, then one has to do the stool cultures, toxin C difficile, and tomodensitometry has to be done. And if there is a pneumoperitoneum or uncontrollable hemorrhage or uncontrollable shock is there, then surgery could be considered. If nasogastric suction, or you can go for nasogastric suction, parenteral nutrition, fluid support and transfusions. In cellulitis, necrotizing cellulitis, septic shock and collection has to be seen. If it is there, then surgery can be there or can go for a conservative management. Broad spectrum antibiotics are stay plus minus antifungal management. Other agents like colony stimulating factors, no difference in the terms of the clinical outcome and occurrence of the nosocomial infections. Granulocyte transfusions, therapeutic administration of granulocyte transfusions in the neutropenic host with severe infection has no proven benefit. Intravenous immunoglobulin, no beneficial effect on IV, MA enriched, IG and MA enriched immunoglobulin therapy in such patients. Reassess your patient, review therapy at 48 hours, patient afebrile, ANC is more than 500, low risk patient, oral antibiotic to be continued and consider early discharge. Low risk patient on IV antibiotic, consider continuing therapy or move it to oral antimicrobials. If patient is high risk category, then pathogen non-identified, discontinue aminoglycosides. So aminoglycosides should be used very cautiously in these patients without any microbiological evidence. So we can discontinue if we don't have got any microbiological evidence after maybe 72 or 48 hours or 72 hours. Continue with other IV therapy in forms of the penems or colistin or any other therapy which is being started. High risk patients, pathogen identified, consider the specific antibacterial therapy as per the sensitivity. If Patient is febrile after 48 hours, then what to do? Patient is stable, continue with the same therapy. If patient is deteriorating, seek expert advice. Don't feel shame in seeking expert advice. Can consult the ID physician and clinical microbiologist to identify and pinpoint the things. When to start antifungal? The IDSA recommends addition of an empiric antifungal therapy after 4 to 7 days in high-risk neutropenic patients who are expected to have a total duration of neutropenia more than 7 days and who have persistent or recurrent fever in whom reassessment does not yield a cause. So choice of agent empiric antifungal therapy depends upon which fungi are most likely to be causing infection as well as the toxicity profile and the cost. So patient never exposed to any antifungal, we can start with fluconazole. Patients with prior exposure of antifungals, echinocandin is the choice. Hemodynamically unstable patients, echinocandin. Patient with pulmonary infiltrate, voriconazole or liposomal amphotericin B can be used. Suspected mucormycosis, amphotericin B is to be used. Duration of the therapy, this is the most important thing. There are different scenarios. Scenario 1, if the ANC is more than 500, the patient is asymptomatic and has been afebrile for 48 hours and blood cultures are negative, then we can discontinue the antibacterials at this point of time. If the ANC is less than 500, patient has suffered no complication and has been afebrile for 5 to 7 days, then antibacterials can be discontinued except in certain high-risk cases with acute leukemia following high dose of chemotherapy, when antibacterials are often continued up to 10 days or until ANC is more than 500. Patients with persistent fever despite neutrophil recovery should be assessed by the ID physician or clinical microbiologist, and antifungal therapy should be considered at this point of time. So there is no role of empiric antiviral therapy in these patients. Acyclovir is recommended for the treatment of varicocele zoster or HSV infection in the presence of clinical or laboratory infection is present. Serological tests should not be used for diagnosis for viral infections. Ganciclovir is recommended for CMV with high risk of CMV reactivation. Patients on T-cell depleting agents such as fludarabine and purine analogs as well as rituximab. Patients on high dose of steroids who develop diarrhea, pneumonia are not responding to antibiotics and antifungals. Neutropenic sepsis is a life-threatening complication of the cancer therapy. Hemodynamically unstable patients and those who develop respiratory and other organ dysfunction are at increased risk for complications and require ICU admissions with higher mortality. Careful assessment and prompt initiation of appropriate antibacterial and antimicrobial therapy is crucial for these patients, and keep local microbiological data while deciding or initiating the antimicrobial choices in these patients is most important. Thank you very much.
Thank you, sir. It's a very excellent presentation. Any question?
Yes, ma'am.
Sir, let's say if there is an indwelling catheter, chemo port or something, and the blood culture comes positive, but the colony count is less. So, do we consider giving local antibiotics, or do we have to remove the port?
So if the port is there, port removal, there are two aspects. One is if you feel that tunnel infection is there or the port site is infected. If they are not, you can continue with the port.
If the colony count is
Less,
less,
yeah.
then
We can continue. Yeah.
Blood culture does not give any colony count. Blood culture is positive.
No, blood culture is not colony count, so it's a time differential. Colony count is important in the BAL, not in the blood culture. In the BAL, we consider the colony count. I am sorry, I missed that part. Pointed out by Dr. Manish and Dr. Sachin. So blood culture is either positive or negative.
Yeah. Thank you, Dr. Govil. You know, one thing which I really like about your presentation is very simple presentation. Black and white, everything is clear. So thank you for taking such an extraordinary lecture. My question is pertaining to the bronchoscopy. You said that in this subset of population, you should do early BAL for them. Any specific reason? Because I am a propagator of bronchoscopy in the patients who are having a VAP.
So any invasive procedure has got its plus and minus. Here in any patient, when we are planning bronchoscopy, especially in a cancer patient or an immunocompromised patient, we have to consider two things. One, during bronchoscopy, are we pushing the upper respiratory tract colonizer to down? That could be one possibility, because I'm sure bronchoscope is well sterilized, but while doing bronchoscopy, it's touching everywhere. So once it is touching everywhere, it can take the upper airway respiratory infection to the down. And side by side, we have to consider, if we don't isolate the organism, then the specific therapy is very difficult. So that is the pro, to isolate the organism, to look what we are dealing with.
So I agree to your, the first point, but in case if the patient has already intubation, which the patient has received, do you still believe this contamination of?
Even in the intubated patient, the upper respiratory airway is there. We are like tube is above the carina. So we are touching the trachea and going down. So that could be one possibility. I'm not saying that it is absolute possibility, but these consideration has to be kept in the mind while doing. Many times what happens, there is a one lobar infection, and while doing bronchoscopy, we do a lavage, we suck it, and then we remove that bronchoscope from that zone and put another area. And then that also can cause the infection to the other zone as well. But I'm not saying these are the contraindication. These things has to consider while doing bronchoscopy.
But what I understood from your presentation, Dr. Govil, that the recommendation is for early BAL in the patients who are having a neutropenic sepsis. So does it in alignment with what you are saying?
Exactly. The early means how early?
Yeah,
early could be 24 hours. Early could be at the time of the diagnosis. Early could be 24 hours. Early could be 48 to 72 hours. What I do in my practice is start antibiotic, wait for another 24 hours. Within 24 hours, if we are not getting the result, go and do the BAL.
Thank you.
Yes, ma'am. Yes, ma'am.
Finding any other focus, there are no catheter, no line infection, urinary catheter is new, you are not getting anything. Do a early HRCT test. Of course, the patient has to be in a stable state, we should say. That gives you a lot of yield, If you find some opacities, X-ray usually misses more than 50% of the chances. We have so many patients who come with fever, we are not finding a focus. We do CT, we see a cavitating nodule. So early HRCT you must do, and if you are not getting an answer from any other source and patient is not responding, then BAL should do that.
HRCT will further direct you to do the BAL.
Yes.
And it will give the answer that which area is to be looked more. So if I am having a opacity in the right lobe, probably I'll do the go in the left lobe first and then go to the right lobe later. If I go to the infected area first and then I move to other area, probably I'll contaminate the other area as well. Thank you very much. Yes, ma'am. Yes. Actually, polymyxin second line, there are 2-3 things. We don't have got clear-cut cutoff for resistance in the polymyxin. So you will find that now every microbiologist, they have given it as an intermediate. So then again, it's a questionable whether to use it or not use it as a first line. But if in my practice, whatever limited practice I am doing with the immunosuppressed patient, we are using polymyxin as a first line. Zevisefta has got a very narrow range. So, and in India, the NDM is quite common. So, unless we do the synergy test and then combining Zevisefta with Aztreonam just without doing synergy test is, to me, it's a little early, and it could be a more narrow approach rather than a broad spectrum. The concept, whatever we have learned in so many years, is to start with a broad spectrum antibiotic, and once the sensitivity is there, then come to a narrow spectrum. Yeah.
It has to be confirmed with the culture, and the cultures are yet not finalized, the break point and all. So still I feel in preliminary practice, we are still using polymyxin and colistin if you think urosepsis, then that area of the thing.
comment about how we measure the carbapenem resistance on the base of the genetic testing. It actually gives you a presence of gene. So the problem is this: most of the time bacteria having more than one mechanism of resistance. So there is a one thing. Second thing, even if genetic code is present, it is not necessary it will be expressed in the function.
Yeah.
So the equation is not really mathematical, which people think just go and the supplement with the combination of the avibactam with the other antibiotic. So still we have to keep our clinical sense intact, and almost a decade polymyxin promised so many lives. So I keep little bit still as a first line where the things really require.
Thank you. Yeah, ma'am, I just wanted to share and supplement what you had said. I think we all do the same thing what you and Dr. Govil and Dr. Jitendra is saying, but the bigger picture, what they are thinking is, they're thinking on the line of polymyxin sparers, because the resistance is becoming a big burden. So somewhere everybody is trying to limit the use of carbapenems and polymyxins. So I think that is the bigger picture which they are looking forward. And absolutely, yeah, yeah, yes, 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 yes.
It's everywhere. Yeah. Yeah.
Yeah, so what Dr. Manish said, polymyxin sparer is ITSA. The same month, there is a review. Are we doing it correctly by saying carbapenem sparer and polymyxin sparer? This editorial is there on the same topic. That it is still not possible to, extrapolate the data in clinical practice.
Okay, thank you very much.
Thank you, Dr. Govil. It was very precise and informative, and brought in a lot of enlightenment to the fellow colleagues as well. So I would now request the chairpersons to kindly felicitate Dr. Deepak Govil. Sir, please. May I now request our senior consultant microbiology, head CSSD and infection preventionist, Dr. Neelam Sachdeva, to kindly felicitate Dr. Sudha Kansal, please. I would also request Dr. Pinky ma'am to kindly come on stage and felicitate Dr. Brij Mohan. Thank you, ma'am. Thank you, sir.